Hello friends. So we are going to discuss the surgery questions of INI-CET May 2023. So welcome once again. We are going to discuss the surgery questions of INI-CET May 2023. Unacademy for NEET PG, there is edge closer to acing your exam preparation. You can get 20% off on all Unacademy subscriptions. What you are going to get: free notes 1.0 plus NEET PG vitals recorded plus free extension up to 3 months. So get 20% off on all Unacademy subscriptions. It is valid till May 13th. So subscribe now. You can subscribe by using my code Dr. Pritesh. There is ultimate next batch. It's a concise batch for next NEET PG 2024 aspirants. The batch started on 29th of April 2023. Duration of this batch is 8 months. You can get your 9 plus 2 months subscription at 17,000 only. What you will be getting here, you will be getting free notes 1.0 plus free NEET PG vitals recorded. Here also to subscribe, you can use my code Dr. Pritesh. So it's time to ace your NEET PG 2023 preparation. Attempt the Unacademy Med Scholar Test Series and stand a chance to win exciting rewards. It will be conducted on 21st of May 2023. There will be 200 questions. The timing of the test would be from 10 a.m. to 1:30 p.m. Okay guys. So now let's start. Tell me, smoking is a risk factor for carcinoma breast, fibroadenoma, Mondus disease, duct ectasia. You tell me guys, what is the correct answer? Yes, all of you know that smoking is a risk factor for carcinoma breast. It's not a risk factor for fibroadenoma. It increases the risk of Mondus disease and it increases the risk of duct ectasia. Clear guys? You tell me, what is Mondus disease? You know, Mondus disease is the superficial thrombophlebitis of inframammary vein. So what is Mondus disease? This is superficial thrombophlebitis. This is superficial thrombophlebitis of which vein? Of inframammary vein. So which veins are involved here? Lateral thoracic. The veins involved are lateral thoracic and thoracoepigastric. Lateral thoracic and thoracoepigastric. Clear? There is another name of Mondus disease, that is what? String phlebitis. So this is also known as string phlebitis. String phlebitis. Clear guys? So tell me, what is the correct answer? Smoking is a risk factor for carcinoma breast. It increases the risk of Mondus disease. It increases the risk of duct ectasia. So 1, 3, 4, these are correct. 1, 3, 4 are correct. Clear? So what is the correct answer here? Correct answer is D. D is the correct answer. Okay. Nat Soben, welcome. Next question. See, which of the following is not an advantage of ultrasonography or mammography in assessment of breast lesions? Okay guys, so first you tell me, what is the first investigation done in a suspected case of breast cancer? I'm waiting for your reply. What is the first investigation done in a suspected case of breast cancer? I'm waiting for your reply. Tell me. First investigation done. Yes, first investigation done in a suspected case of breast cancer. Nat Suben, tell me. I'm waiting for your reply. Yes. Guys, it is mammography. So mammography is the first investigation done in a suspected case of breast cancer. But what is the problem with mammography? If age of patient is less than 35 years, if patient is young, so what is the problem in young females? Young females have dense and glandular breast? Since young females are having dense and glandular breast, it is going to decrease the sensitivity of mammography. Clear? So, first investigation done in a young female age less than 35 years with breast lump, it becomes ultrasound. So, young females, very good. Salini Shubhas, very good. So, young females age less than 35 years plus lump, the first investigation is ultrasound. That is ultrasound. What is the other role of ultrasound? You know that ultrasound can differentiate solid lesions from cystic lesion, and if you want to go for a guided biopsy, we can go for ultrasound guided biopsy. But the problem, what is the problem? If some lesion is not detected by mammography, it's very difficult to detect that lesion by ultrasound. Why? Because the sensitivity of ultrasound is lesser than mammography. So now see the options. It is useful in young females with dense breast, correct? Can differentiate cystic lesions from solid lesions, correct? Help in guided biopsy, correct? Can help to localize mammographically undetectable palpable lesions, no. If the lesion cannot be detected by mammography, it is very difficult to detect it by ultrasound. So, incorrect option is D, and that is the correct answer. Salini Shubhas, you are correct. Now see third question. Which of the following procedures are considered for breast conservation surgery? Tell me guys, what is your answer? Following procedures are considered for breast conservation surgery. Yes? So let me tell you what we do in breast conservation surgery. You can see this is the breast. Here you can see this is the nipple and this is the areola. Imagine this is the lump. So what I'm going to do, in some of the patient, I'm just going for excision of lump, and if you just excise the lump, this is known as lumpectomy. If you just excise the lump, that is lumpectomy. If I take margin, 1 centimeter margin, if I'm going to take, this is known as wide local excision. So second surgery, I can go for wide local excision with 1 centimeter margin. Clear guys? And what is the third surgery we can go for? We can go for excision of whole quadrant. So if you excise the whole quadrant, this is known as quadrantectomy. If you go for excision of whole quadrant, this is known as quadrantectomy. It means in the breast conservation surgery, what you are going to do, you are going to remove lesion and some part of breast tissue, but rest of the breast is left as such. That's why in the post-operative period, in all patients, what I have to give? Radiotherapy. Second, whenever we are performing breast conservation surgery, we perform sentinel lymph node biopsy or we go for axillary lymph node dissection. Third, we can send intraoperative frozen section also. So frozen section is also required. Clear? So see the options. Wide local excision of tumor is done, correct. Post-operative radiotherapy is optional, no, it is mandatory. This is mandatory. Very good. Roshan Vasudevan, correct. It is mandatory. Intraoperative frozen section is required. This is correct. Axillary lymph node dissection is done, correct. So correct answer is 1, 3, 4. It is 1, 3, 4. That is correct. Clear? So it is B which is correct. B which is correct. Okay. So it is B which is correct here. Okay guys. It is B. Next. Best line of treatment for HER2 new positive trastuzumab resistant breast cancer. So guys, first you tell me which chemotherapy is preferred in breast cancer. Yes, we give CAF. What is the full form? Cyclophosphamide, adriamycin 5-fluorouracil. So we give this adriamycin based chemotherapy. Clear? Now imagine if I am giving adriamycin and what happens, patient is not responding. Patient is having adriamycin resistant breast cancer. So for adriamycin resistant breast cancer, tell me which agent should be given. For adriamycin resistant breast cancer, we give taxanes. Now you tell me guys, what are the agents we give? Which one? Which taxanes we give? Docetaxel and paclitaxel. So here we give what? Docetaxel and we give paclitaxel. Okay. Second, if it is resistant to both adriamycin as well as taxanes, which new drug is given? We give ixabepilon. So we give a new drug, and what's the name? It is ixabepilon. The name of drug, this is ixabepilon. It's a new drug for adriamycin and taxane resistant breast cancer. Adriamycin and taxanes resistant breast cancer. Resistant breast cancer. Clear? Another situation, if patient is having HER2 new positive breast cancer. HER2 new positive breast cancer is there, the first line agent is trastuzumab or Herceptin. So if patient is having HER2 new positive breast cancer, the first line agent we give Herceptin, also known as trastuzumab, and the second line agent, that is lapatinib. Okay guys, so tell me what is the correct answer here? The correct answer for this question is what? Lapatinib, because patient is having HER2 new positive trastuzumab resistant breast cancer. Now question for all of you, in which case we give sorafenib? I am waiting for your reply. Tell me. Salini, Shubhas, you are correct. Roshan, tell me, waiting for your reply. In which case we give sorafenib. So sorafenib is given in advanced and metastatic HCC. This one is given in advanced and metastatic HCC, metastatic hepatocellular carcinoma. Another agent is vemurafenib, and this vemurafenib, it is used for late stage melanoma. Vemurafenib, this is used for late stage melanoma. And you must be knowing erlotinib. What is the role of erlotinib? It is used in non-small cell lung cancer and advanced pancreatic cancer. So used in non-small cell lung cancer. So non-small cell lung cancer and advanced pancreatic cancer. We give it in advanced pancreatic cancer. Clear guys? So what is the correct answer here? Since the patient is having HER2 new positive trastuzumab resistant breast cancer and the second line agent, that is lapatinib. Okay, lapatinib. Nat Sobin, very good. Dr. Roshan Vasudevan, very good, you are correct. Next, this is very easy question. See, 27 years old female presents with thyroid swelling that compresses the nearby structure. Match the pressure effects of thyroid swelling. So it's very easy. Obviously, when trachea is compressed, what is the symptom? Dyspnea. When recurrent laryngeal nerve is compressed, there is hoarseness of voice. Esophagus is compressed, patient will be having dysphagia. And you know, when sympathetic chain is compressed or cervical sympathetic trunk is compressed, there is Horner syndrome. So what is the correct answer here? Guys, you can tell me. 1B, 2C, 3D and 4A. Clear? Okay, Roshan, Bibin, Chinayan, very good. So 1B, 2C, 3D, 4A. So correct answer is option number A. This is correct. Clear? 1B, 2C, 3D, 4A. Okay. Now see this question, very easy question. A patient presented with complaints of dysuria and pain in the flank. X-ray of the patient is given below. What is the most probable diagnosis? First you tell me guys, what is the diagnosis here? On the X-ray, what you can see here, tell me the diagnosis. Nat Soben, Salini, Shubhash, very good, both of you are correct. First tell me what you can see in the X-ray. So guys, you can see in this X-ray that patient is having multiple kidney stones and these are present bilaterally. So bilateral multiple kidney stones. Now what happens? See the options. Obviously there is no relation of stones with Wilms tumor, no relation with RCC, but stones are seen in polycystic kidney disease. But if you compare parathyroid adenoma is the most common cause of primary hyperparathyroidism. Parathyroid adenoma, This is the most common cause of primary hyperparathyroidism. And all of you know that in primary hyperparathyroidism, there is increased secretion of parathyroid hormone. Because of this, what will happen? There is increased calcium level, means in primary hyperparathyroidism, patients are having hypercalcemia. And because of the hypercalcemia, patients are going to develop kidney stones. Not only kidney stones, in primary hyperparathyroidism, there is a pentad. Kidney stones, painful bones, abdominal groans, psychic moans, fatigue overtones. I am repeating, kidney stones, painful bones, abdominal groans, psychic moans, fatigue overtones. Clear guys? So it is caused by primary hyperparathyroidism leading to hypercalcemia, and the most common cause of hypercalcemia, that is primary hyperparathyroidism, that is parathyroid adenoma. Clear? So Nat Soben, you are correct. Bibin Chinnayan, you are correct. Very good guys. So next question. Very easy question. Tell me, most common cause of adrenal incidentaloma. Tell me guys, what is the correct answer here? Most common cause of adrenal incidentaloma. Very easy question. I'm waiting for your result. I'm waiting for your reply. Salini, Roshan. Okay. So it's very easy guys. The most common cause of adrenal incidentaloma, that is non-functioning adenoma, in what percentage of cases? In 82%. Preclinical Cushing's responsible for 5%. Pheochromocytoma responsible for 5%, and aldosterone secreting adenoma, this one is responsible for 1% of adrenal incidentaloma. So what is the correct answer? Correct answer for this question is option B. It is option B. Okay. Adrenal incidentalomas, these are very important, frequently asked. So we discussed non-functioning adenoma, it is responsible for maximum number of cases, 82%. If you see preclinical Cushing, pheochromocytoma, adrenocortical carcinoma, these are responsible for 5%. Metastatic carcinoma, 2%, and least common is aldosterone producing adenoma, which is responsible for 1%. So most common non-functional adenoma, least common aldosterone producing adenoma. Okay guys, aldosterone producing adenoma. Shalini, very good. Now see this question and tell me the answer. Question number 8, easy question. 35 years old patient with history of blood stained motions for the last 6 weeks, means patient is having dysentery, complains of fever and pain in right upper quadrant. So there is fever, pain in right upper quadrant and dysentery. On ultrasound there is hypoechoic cavity in the right lobe of liver. You can see here hypoechoic cavity in the right lobe of liver. Now tell me what is the correct answer. Guys, tell me what is the correct answer. Waiting for your reply. Shalini, Roshan, Rahul, Bibin, tell me what is the correct answer. This is very easy question. Roshan, you are correct. Roshan, correct. Now see, what are the clues? First, patient is having diarrhea or dysentery. In all of these 4 conditions, diarrhea or dysentery, it is only associated with amoebic liver abscess. It is not seen in pyogenic liver abscess or hydatid cyst. Next, there is no fever in hydatid cyst until and unless there is secondary bacterial infection, no fever in hemangioma. So if you have to differentiate amoebic liver abscess and pyogenic liver abscess, in both there is fever, there is abdominal pain, but history of diarrhea or dysentery, it is seen in amoebic liver abscess. Second, in pyogenic liver abscess, patient age is around 60. Patient is alcoholic. But in amoebic liver abscess, patient is from developing countries, patient is young, or there is history of travel to endemic areas. So which organism is responsible? Ent amoeba histolytica. And what is the route of infection? Feco-oral. So what is the correct answer guys? Correct answer is amoebic liver abscess. Clear? Roshan, Vasudevan, Bibin Chinnayan, Nat Soben, all of you are correct. Now tell me guys, what is the gallbladder anomaly shown in the ultrasound? Gallbladder anomaly. Tell me. Very easy question. Gallbladder anomaly shown in the ultrasound. Very good, Roshan Vasudevan. Flask-shaped ulcer is seen in amoebic colitis. Yes, very good. Bibin, you are correct. So very easy. You can see here, this is the body and this is the fundus. So there is infolding of septum. You can see here, infolding of septum between body and fundus, and this is known as Phrygian cap. And you know, Phrygian cap is the most common anomaly of gallbladder. Clear? What is Mercedes-Benz sign? All of you must be knowing. If gallstone is there and there is triradiate fissure, this triradiate fissure is known as what? Mercedes-Benz sign. So correct answer is Phrygian cap. How this Phrygian cap looks like? Can you see here? This is Phrygian cap. So in the image you can see this is fundus, this is body, and you can see infolding of septum. So infolding of septum between fundus and body, this is Phrygian cap, most common anomaly of gallbladder. Important point. Here, gallbladder functions are normal. That's why we are not going for lap cholecystectomy. So in Phrygian cap, cholecystectomy is not recommended. Why? Because the functions are normal. Okay, tell me this question, guys. This is a repeat question. Tell me this question. Tell me, guys. After laparoscopic cholecystectomy, what should be the urine output of the patient if renal function of the patient is normal? Waiting for your reply. What should be the urine output? Yes, Roshan, very good, but that's not correct answer. Yes, that's Nat Soben, that is also not the correct answer. Roshan, no, that's not the correct answer. Tell me. See, it's very easy. Sometimes the question is asked in this format, ml per hour. So, you know that urine output is the best clinical indicator of tissue perfusion. How much should be the urine output, minimum urine output? In adults, the minimum urine output should be how much? 1 ml per minute. 1 ml per minute. Or if you are going to label it or express it in ml per kg/h, then it is 1 ml per kg per hour. Clear? In both the values will be same. If you calculate the total value per hour, this is 60 ml. And if you consider that the body weight of a reference adult 60 kg, so here also the value is 60 ml. Now see in children, how much should be the urine output in children? In children, the urine output should be 0.5 to 1 ml per minute, or it is 0.5 to 1.5 ml per kg per hour. Clear, guys? So that's why it's very, very important. So what is correct answer? If we are talking about children, this value 0.5 to 1.5 ml per hour, it is correct for children, but 1 ml per kg per hour, this is for adults. Clear? So what is the correct answer here? Correct answer for this question is option D. Option D, that is the correct answer. So it is option D, that's the correct answer. Yes, Roshan, what you want to say? They didn't mention age. Yes, they didn't mention age. We have to accept that after lap cholecystectomy, what is the age for lap cholecystectomy when patient is going to develop gallstone? And at what age usually gallstone develops? It is said that a fat, fertile, flatulent female of 40. If they didn't mention age, we have to accept that patient is an adult. Got it? Otherwise, in children, gallstones are not very common until and unless they have some kind of hemolytic disorders. Clear? So correct answer is D. Now see the next question, guys. It's very easy. What is the diagnosis based on the given image showing filling defect on MRCP? So in this MRCP you can see what? You can see that multiple rounded opacity. Here black shadows. These are the multiple shadows. Clear? So what? These patients are having multiple stones where? Multiple stones in the bile duct. So in bile duct on MRCP there are multiple stones. Clear, guys? So this is bile duct having multiple stones. So obviously what's the diagnosis here, guys? The correct answer is choledocholithiasis or CBD stone. You know that cholecystitis, it is diagnosed by ultrasound. In stricture, obviously there will be narrowing. If there is pancreatic duct calculi, you can see here, this is the pancreatic duct, and in the pancreatic duct, if calculi is there, you can also diagnose it. So here, this is choledocholithiasis. Correct answer is B. Now, one question to all of you. Tell me, what is the gold standard investigation for CBD stone? Tell me, guys. Gold standard investigation. I am waiting for your reply. Yes? So it's easy. There are two investigations, MRCP. MRCP is having very high sensitivity. This is the investigation of choice for diagnosis. Nat Soben, you are correct. Jiten Yadav, MRCP, it is the investigation of choice. But for CBD stone, ERCP, it is gold standard. Now you know why ERCP is gold standard, because you know that it is diagnostic and it is therapeutic. So it can diagnose CBD stone, it can remove the CBD stone. So in this image you can see 1, 2, 3. There are 3 CBD stone on MRCP, and ERCP, can you see? There are multiple CBD stones, not only in the CBD, there are stones in the cystic duct also. Clear, guys? So gold standard, it is ERCP. Now one question for all of you. What is the maximum size of stone removed by ERCP? Maximum size of stone removed by ERCP. Arisha Khan, Jiten, tell me. Maximum size of stone removed by ERCP. And the maximum size removed, that is, yes, 1.5 centimeter. So yes, Jiten Yadav, you are correct. Maximum size of stone removed by ERCP, that is 1.5 centimeter. Very good. Clear? Now see the next question. Again, very easy question. 20 years old male patient comes to OPD with severe vomiting for 2 days, orthostatic hypotension. There is fluid loss because of vomiting. Which of the following complication can be seen in this patient? So it is very easy. If a patient is having multiple episodes of vomiting, what will happen? See, this patient is having multiple episodes of vomiting. So there will be loss of gastric juice. And you tell me, what is present in gastric juice? It is rich in acid, HCl, it is rich in potassium. So there will be loss of HCl and potassium. If there is loss of H+, so what will happen? Loss of H+, patient will be having metabolic alkalosis. Second, loss of chloride. So the patient will be having hypochloremia. Loss of potassium. So patient will be having hypokalemia. Clear, guys? So this patient will be having hypokalemia, hypochloremia, metabolic alkalosis. Respiratory alkalosis is not seen. Yes, very good. Respiratory alkalosis is not seen. So guys, tell me what is the correct answer. Yes, 1, 2, 3 are correct. So let me see. Nat Soben, you are correct. So it is 1, 2, 3. So B is correct answer. For this question, correct answer is B. Nat Soben, you are correct. Now see this question. Yes, very, very easy question. Match the location of appendix with given image. Location of appendix with given image. Okay. First, tell me, guys, what is the location of A? A. This is A. What is the location? A. You can see. A is located behind cecum. So this is retrocecal. So you can see A. This is retrocecal. This part is ileum. Now B is behind ileum, C is in front of ileum. So B, this is post-ileal. B is post-ileal. C, it is located in front of ileum. Very good. Nature with medicos. Very good. So C, this is pre-ileal. Pre-ileal. You can see D, its orientation is towards pelvis. So this one is pelvic. And E, behind cecum, but not exactly behind. Yes, E, this is subcecal. Behind as well as below. So this is subcecal. Got it, guys? So A, retrocecal, B, post-ileal, C, pre-ileal, D, pelvic, and E, subcecal. So what is the correct answer? Guys, the correct answer for this question is D. So D is correct answer for this question. Roshan Vasudevan, again you are correct. Very good. Again Roshan, you are correct. Nat Sobin, correct. So Nat Sobin, you are also correct. Clear? So see guys, there are questions which are asked in relation to location of appendix. Now retrocecal, this is the most common location. Most common location of appendix, that is retrocecal. After that, what is the least common location? You can see post-ileal. So post-ileal, this is least common. And you tell me guys, which one is the most dangerous location of appendix? Tell me, which one is most dangerous location of appendix? Most dangerous. Waiting for a reply. Which one is most dangerous location of appendix? Yes, Shalini, Nat Soben, Jiten Yadav, Nature with Medicos. Tell me. The most dangerous location, it is pelvic. No, Nat Soben, it's not retrocecal, it is pelvic. Sudipta Roy, Jiten Yadav, both of you are correct. Sudipta Roy, Jiten Yadav, both of you are correct. Yes, it is pelvic. Snowcast, it is pelvic. So why pelvic appendicitis is most dangerous? See, whenever the orientation is towards pelvis and patient develops acute appendicitis, the abdominal signs and symptoms are not marked. If abdominal signs and symptoms are not marked, in that case the diagnosis is delayed. So if there is delay in the diagnosis, what will happen? There is increased risk of perforation. So that's why pelvic appendix, pelvic, yes, it is most dangerous location. Why it is most dangerous location? This is most dangerous location because in pelvic appendicitis, signs and symptoms, which signs? Abdominal signs and symptoms are not marked. That's why there is delay in diagnosis. It increases the risk of perforation. So I'm repeating 3 questions. Most common location, retrocecal. Least common location, post-ileal. Most dangerous location, pelvic. See this question guys, very easy question. Roshan, very good. Now see this question, very easy. 73 years old patient presents with complaint of per-rectal bleeding, means bleeding PR. At 73, it could be manifestation of colorectal cancer. Now see, what is the best investigation that can be done in this patient? So I'm asking only one investigation which is best. Out of these 4, which one is best? Okay, Jiten Yadav, you are correct. I'm not asking that what are the investigations which can be done. I'm asking first which one is best. Best is only one. Dr. Roshan Vasudevan, you are correct. Colonoscopy. So if question is asked which one is best, you have to choose one. Colonoscopy plus biopsy, this is best. But if the question is asked that what are the investigations that can be done, so investigations which are done in a suspected case of colorectal cancer, colonoscopy plus biopsy for diagnosis. CEA, it's a tumor marker which is raised, and CET is done especially in carcinoma colon. Why? For staging. So CET it is done for staging. All of you know that CA99 is a specific tumor marker for which malignancies? Tell me guys. CA99 is a specific tumor marker for which malignancies? Tell me. It is raised in carcinoma gallbladder, in cholangiocarcinoma, and in which malignancy? Carcinoma pancreas. So CA99, it's not a tumor marker for colorectal cancer. So if you choose what investigations which can be done, A, B, D, these are the investigations which can be done, and if you have to choose one best, that is colonoscopy. Clear guys? Colonoscopy. So Jiten, Sudipta Roy, Nat Soben, all of you are correct. It is A, B, D, and if you have to choose one, colonoscopy. Now tell me guys, what is the correct answer here? It's a repeat question. Which of the following is not a perineal approach for rectal prolapse? Waiting for your reply. Snowcast, Jiten Yadav, very good. You are correct. You are correct. Clear? So there are two approaches for ectopexy. One is abdominal and one is perineal. So we have two approaches. One is abdominal and the second is perineal. Clear? In abdominal, what are the rectopexies done? Mnemonic is var. And in perineal, it is pad. So how to remember? W means Wells, A means abdominal, R means Ripstein. So Wells and Ripstein, these are abdominal, and in perineal, P means perineal, A means Altmaiers. Clear? So A means Altmaiers, D means Delorme, and there is third procedure which is done known as Thiersch anal wiring. This is what? Thiersch anal wiring. Clear? So Altmaiers, it is perineal, Delorme is perineal, Thiersch anal wiring is perineal, Ripstein, it is abdominal. So correct answer for this question, Ripstein. Majority of you were correct. Majority. Okay guys? Now see this question. This is a new question. It was asked for the first time. Let me see who is going to mark the correct answer. A clinician during examination of inguinal hernia forcefully reduced the sac in abdominal cavity without actually pushing back the content. Clear? Identify the type of hernia with the image given below. Type of hernia. So first see what examiner did. Yes, he reduced the sac without pushing back the content, means he reduced it en masse. This kind of reduction is known as en masse reduction. Reduction en masse. But this is not the question. The question is type of hernia. If the question is asked type of procedure done, this is reduction en masse. So in which hernia we are going for en masse reduction? You can see here the bowel, small intestine, it is still located within the sac, and this is what? Incarcerated hernia. What is this hernia? This is incarcerated hernia. So in incarcerated hernia, we can go for en masse reduction. Second, you can see guys, this is the sac for indirect inguinal hernia and this is the sac for direct inguinal hernia. So any patient in whom you are going to find the sac for both direct inguinal hernia and indirect inguinal hernia, this is known as combined hernia, also known as pantaloon hernia. So if you see, actually speaking, this is combined hernia. Clear? Also known as pantaloon hernia. Why? Because here there is sac for direct inguinal hernia as well as indirect inguinal hernia. And what kind of indirect inguinal hernia is there? This is incarcerated. Clear guys? So this is incarcerated. So correct answer, it is A. Name of this procedure, reduction en masse. Clear? What is sliding hernia? In sliding hernia, posterior wall of sac is formed by viscera, and medial hernia, it is W-shaped hernia. See? First you can see here, this is the direct portion of sac, direct hernia sac. This is indirect hernia sac. This is actually incarcerated hernia where we did reduction en masse. Now you can see what is the name of this hernia. Here, the posterior wall of sac is formed by viscera, and this is known as sliding hernia. Guys, you tell me what is the other name of this sliding hernia? Roshan, it is not paraesophageal hernia. Paraesophageal means side of esophagus. This is intestinal, inguinal hernia. This is not paraesophageal hernia. Okay. So sliding hernia, which is also known as hernia englisade. This is also known as hernia englisade. Here, the posterior wall of sac is formed by viscera. You know it is more common in males. And what is the most common content? Sigmoid colon. You can see here it is sigmoid colon. And if you are talking about right side, on right side, what is the content? On right side, the content is cecum. The content is cecum on right side. Okay guys, so this is sliding hernia. Now what is medial hernia? You can see it is W shaped hernias. In large hernia sac, you can see the shape is like W. Okay, so this central part of W, it is located within the abdomen. So this central portion of W, this is located within the abdomen, and this is usually strangulated. Clear? Rest, it is located within the sac, and it's a complication of large hernial sac. So what is known as, it is known as Madel's hernia. This is Madel's hernia. Clear guys? This is Madel's hernia. Okay. For sliding hernia, Roshan Sugathan, for sliding hernia, it's a clinical diagnosis. Whenever we are performing the surgery and you are going to see that the posterior wall of sac is formed by viscera, so it's a clinical diagnosis during surgery. Now another very easy question, tell me guys, what is the baseline platelet count required for surgery? Let me see who is going to mark the correct answer. Baseline. Yes, Jiten Yadav, very good Jiten, very good Snowcast, very good Snowcast. Yes, so the baseline platelet count for non-neurological surgery, it is 50,000, and if you go for neurosurgery, it is 1 lakh. Clear? So for non-neurological surgery, this is 50,000 per microliter, and for neurosurgery this is 1 lakh per microliter. So nothing is mentioned here. We are going to assume that it is non-neurosurgical operation, general surgical operation, and what? Baseline platelet 50,000. So baseline platelet count required for surgery 50,000. So you can see here, for neurological surgery, non-neurological surgery, clear, count of 50,000 per microliter is considered, and 1 lakh per microliter, especially for neurosurgical operations. So for neurosurgical operation 1 lakh, non-neurosurgical operations 50,000. Guys, this is a repeat question and it's very easy question. Tell me what is the correct answer. I am waiting for your reply. After varicocele surgery, venous drainage of testis occurs by. Tell me, I am waiting for your reply. Jiten, Snowcast, Shalini, Shudipto, tell me. Snowcast, in dengue there are various criteria. Usually it should be less than 20,000. Okay, I am waiting guys. Tell me, what is the answer? Answer, this is very easy question. Venous drainage of testis occurs by after varicocele surgery. Yes, Snowcast, it's not correct. Yes, I'm waiting for a reply guys. Let me see who's going to reply first. Yes, let me tell you what is the correct answer. It is cremasteric veins. Bibin, Snowcast, Bibin, very good. It is cremasteric veins. So venous drainage occurs by cremasteric veins. This is the correct answer, cremasteric veins. Now see what happens in varicocele. In varicocele you can see there is dilated tortuous pampiniform plexus of veins. What is the location? Located posterior and above testis. You can see. If patient does the palpation, on palpation what kind of feeling is there? Bag of worm. There is bag of worm like sensation. Bag of worm like sensation. Clear? And what we do in patients of varicocele, we are going to ligate pampiniform plexus of veins. So where we are going to ligate, you can see here, this is deep ring, this is the superficial ring. You can ligate it here, where? Close to deep ring. And if you ligate it close to deep ring, this is known as high inguinal ligation. This is known as high inguinal ligation of pampiniform plexus of veins. High inguinal ligation. Clear? if you ligate it in retroperitoneum, you ligate left testicular vein or left gonadal vein in retroperitoneum, this is known as Palomo's operation. Palomo's operation. And sometimes we can ligate it here below inguinal region. Below inguinal region. So this is microvascular subinguinal ligation. What's the name? This is microvascular. This is microvascular. What kind of ligation? This is subinguinal ligation. So microvascular subinguinal ligation. So what we are doing, we are ligating the pampiniform plexus of veins. And if you are ligating pampiniform plexus of veins, what will happen? There must be some alternative venous drainage channel. And what is that venous drainage channel? The alternative venous drainage channel, that is cremasteric veins. Guys, this is a repeat question actually. Alternative venous drainage channel, that is cremasteric veins. Clear? So majority of you were correct for this question. Majority of you were correct. So correct answer was cremasteric veins. Clear? Now another very easy question. This is asked in anatomy also, asked in surgery also, asked in gynae also. Tell me what is the correct answer here. Guys, tell me what is the correct answer. Yes. What is the cause of absence of fructose in seminal fluid? Clear? Very good. Now let me tell you, this fructose is secreted by which particular gland? It is secreted by seminal vesicle. Seminal vesicle. Okay. So whenever any patient in whom this seminal vesicle is absent, if seminal vesicle is absent, what will happen? There is no fructose. Or if the duct of seminal vesicle is obstructed, there is no fructose. So ejaculatory duct obstruction and congenital absence of seminal vesicle, in both of these cases there is no fructose. In which patient of vas deferens obstruction there is no fructose? If vas deferens obstruction occurs at or before ejaculatory duct. If it occurs at or before ejaculatory duct, only in those cases there is absence of fructose. So if you have to choose multiple options, you can choose A and B. And if you have to choose single option, you can choose all of the above. All of the above, because in some patients where vas deferens is obstructed at or before ejaculatory duct, there is absence of fructose. Clear? Now see this, guys, again this is a repeat question. Which of the following statements are true about peripheral arterial occlusion? So first you tell me, guys, what is the most common cause of peripheral arterial occlusion? I am waiting for your reply. Most common cause of peripheral arterial occlusion. Tell me. Easy question. It is mentioned also. So peripheral arterial occlusion, the most common cause, yes, no, Bibin, it is not tau. Peripheral arterial occlusion, most common cause is atherosclerosis. It is atherosclerosis. In young males smokers, it is Burgess disease. Got it? Now what happens whenever there is peripheral arterial occlusion? Whenever muscles are doing work or exercise, there is ischemia. And because of ischemia of muscle, if pain is there, this is known as intermittent claudication. So intermittent claudication, it is because of ischemia of muscles. This is because of ischemia of muscles. Okay. Another factor, some patients of Burgess disease, they have rest pain. Why? Because there is cutaneous ischemia. This rest pain is usually seen at night when patient is going to sleep, because patient is going to sleep in supine position. So whenever there is pain, what happens? This patient is going to hang the legs by side of bed, so that with the help of gravity some amount of blood should be reaching the ischemic areas. If you remember, there is a classification system for intermittent claudication, and what is that? It is Boyd's classification. This is Boyd's classification. That is the grading of intermittent claudication. Grade 1, pain appears at the start of walk but disappears if patient continues to walk. So when patients start doing work or exercise or walking, pain can appear. Clear? And depending upon the peripheral arterial occlusion, if imagine aortoiliac bifurcation is the site of obstruction, the patient will be having intermittent claudication or claudication of gluteal region, thigh, calf. And if there is involvement of popliteal artery or crural artery, there will be calf claudication only. Got it? Means the clinical picture depends on the site of obstruction. So see the options. First, rest pain is seen at night. Correct? Pain of intermittent claudication starts on taking the first step. Correct? Atheroma or atherosclerosis, most common cause. Correct? Clinical picture does not reflect the site of peripheral arterial obstruction. This is incorrect. So all except we have to choose. So what is the correct answer for this question? Correct answer is D. So Salini Shubhas, Roshan Vasudevan, Nat Suben. Yes, majority of you are correct. So correct answer for this question is D. Now see guys, depending upon the site of block, see the clinical presentation. So first thing, clinical presentation depends on the site of block. So if patient is having aortoiliac disease, there is buttock, thigh, calf claudication, and there can be Leriche syndrome, which is also known as erectile dysfunction. Leriche syndrome, there is erectile dysfunction because the patient will develop impotence when the obstruction is at aortoiliac bifurcation. In common femoral disease, thigh and calf claudication. If patient is having superficial femoral, popliteal or crural artery disease, in all these cases there is calf claudication. Clear guys? So majority of you were correct. Now see this question and tell me what is the name of this test. Very easy. Tell me guys, what is the name of this test? Waiting for your reply. Roshan, Jiten, very good Jiten, Roshan, Salini, Netsoben, yes, Snowcast, correct? Yes, majority of you are correct. Majority. Arisha Khan, all of you are correct. So guys, this is Allen's test. What we have to assess whenever we are going for ligation of any AV fistula or creation of AV fistula in the forearm, we have to check the patency of radial artery and ulnar artery, and we have to check the integrity of palmar arch. So we ask the patient to make a fist. After that, we are going to occlude both of the arteries. You have to see that the tip of fingers should be having, it should appear pale and release one artery, and you have to see whether there is integrity of palmar arch or not. So this is Allen's test which is done. Before creating AV fistula, we have to assess the patency of radial and ulnar artery and integrity of palmar arch. This is Allen's test, option number D. Clear? So Allen's test, it is done for the adequacy of blood supply to the hand from the radial and ulnar arteries and arcade between them. Clear guys? So this is Allen's test. Next, very easy question. Again, it's a repeat question. See, patient presented with dull aching pain along with, see, dull aching pain along with dilated and tortuous vein of both lower limbs. Obviously, what is the diagnosis guys? Tell me. Harry, Nature with Medicos, Salini Shubhas, tell me the diagnosis. Dull aching pain, dilated and tortuous veins of lower limb. Simple question. So obviously it is varicose vein. Patient is having varicose vein. Now see, which of the following test helps in clinical diagnosis of SFJ incompetence? Okay, one by one we are going to discuss. First, you tell me guys, what is this Fagan's test? We have to perform the deep palpation along long saphenous vein. And if there is incompetent perforator, what you are going to notice, there is crescentic defect in fascia. So in Fagan's test, there is crescentic defect in fascia. Okay, at the site of incompetent perforator. at the site of incompetent perforator. Clear? What is Morrissey's test? This is cuff impulse test. Morrissey's test, this is cuff impulse test. Okay, what is Perthes test? So whenever we apply elastic bandage in the lower limb and ask the patient to perform work or exercise. Now see the anatomy. This is femoral vein and this is long saphenous vein. This is saphenofemoral junction. So whenever you are going to apply elastic bandage, you are going to obstruct the superficial system. So during work or exercise, if patient develops severe crampy pain, it means there is obstruction of deep venous system. So that is Perthes test, suggestive of DVT. Rather than applying the elastic bandage, we can apply tourniquet around saphenofemoral junction, ask the patient to do the work or exercise. If during work or exercise patient develops severe cramping pain, it means there is obstruction of deep venous system, means DVT. So modified Perthes test, yes, it detects DVT. Now see here, these are the perforators. And you tell me what is the direction of valves in the perforator? Direction of valve is like this in deep veins towards heart, in perforator like this, saphenofemoral junction like this. So what happens? First we ask the patient to lie in supine position, you elevate the limb, perform the milking. After milking, you apply pressure over saphenofemoral junction and ask the patient to stand. The moment you are going to release the pressure, there is rapid blood column filling from above. So if filling occurs from above, it means saphenofemoral junction is incompetent. In second situation, you don't release the pressure and there is slow filling from below. So if there is slow filling from below, it is suggestive of what? Incompetent perforator. So component 1, suggestive of incompetent SFJ. Component 2, incompetent perforator. So correct answer for this question is D. D. Okay. So let's quickly revise. Morrissey's test, you know it's a cuff impulse test. Perthes test, tourniquet is applied. Patient is asked to do work or exercise. If patient develops severe cramping pain, it is suggestive of deep venous obstruction. And Fagan's test, there is facial defect. So at the site of incompetent perforator, crescentic defect in fascia. And here guys, you can see what is the component 1 of Brody-Trendelenburg test. When the pressure is released at SFJ, varices fill quickly by column of blood from above. So filling occurs from above means incompetent SFJ. And what is component 2? In component 2, the pressure is not released. So varices fill gradually from below. It is suggestive of incompetent perforators. So what is the name of this test? Brody-Trendelenburg test. Component 1 test incompetent SFJ and component 2 test incompetent perforators. Again, very easy question guys. I am waiting for your reply. Tell me what is the correct answer. Which of the following statement is correct about thymoma? Tell me. Roshan Vasudevan Pratt test. Whenever we are going to squeeze the calf, this is Pratt test. Pratt test, it is positive in DVT. It is not related with varicose vein. Okay. Very good, Jiten Yadav, you are correct. Jiten Yadav, see the question. Correct option you have to choose. Correct option. Snowcast, Jiten Yadav, Nat Soben, Salini Subhash, Arisha Khan. Yes, all of you are correct guys. So see, thymoma, you know, it is the most common neoplasm of thymus. It is located in which mediastinum? It is located in anterior mediastinum. Clear? X-ray is investigation of choice. No guys, it is CT scan. Because there is mediastinal pathology for most of the mediastinal masses. Investigation of choice, CT. There is one exception. You tell me which one? Neurogenic tumor. If patient is having neurogenic tumor, for neurogenic tumor investigation of choice is MRI. Clear? Next, usually symptomatic. No, it is usually asymptomatic. And whenever advanced means the size of tumor is large, it can compress trachea. There is dyspnea, it can compress esophagus, dysphagia, or it can compress superior vena cava, leading to superior vena cava syndrome. Very good, Snowcast, you are correct. So correct answer for this question, it is most common neoplasm of thymus. Now see the anatomy. If you see the location, this is superior vena cava draining into right atrium, and you can see thymoma. So whenever the tumor is there, this tumor can obstruct superior vena cava syndrome. It can obstruct trachea, so dyspnea, and it can obstruct esophagus. So the patient will be having what? Dysphagia. Clear, guys? Now another very easy question, very easy and repeat question. Tell me, which of the following salivary gland tumor is associated with perineural invasion? I am waiting for your reply. Easiest question. Snowcast, Roshan, Arisha Khan, Harry, tell me. Jiten Yadav. Salivary gland tumor associated with perineural invasion. Easiest question. Snowcast, you are correct. Jiten Yadav, correct. So guys, it is adenoid cystic carcinoma. So you know, adenoid cystic carcinoma, it is associated with perineural invasion. Now can you tell me, is the most common malignancy of minor salivary gland? Most common malignancy of minor salivary gland. Tell me which nerve it is going to involve. It is going to involve facial nerve and trigeminal. Okay. What about pleomorphic adenoma? This is the most common salivary gland tumor. What is mucoepidermoid carcinoma? This is most common malignant. This is most common malignant salivary gland tumor. And Warthin's tumor, this is exclusively seen in parotid. Exclusively in parotid. It is more common in males. This is more common in smokers, and it shows hot spot on technetium pertechnate scan. Hot spot on technetium pertechnate scan. Clear? So all these are question, guys, related to salivary gland tumors. Which tumor is having perineural invasion? Adenoid cystic carcinoma. Easy question, repeat question. Tell me what is the correct answer here. You can see the swelling. Tell me the correct answer. Roshan, you are correct. Snowcast, tell me the correct answer for this question. Roshan, correct. Jiten, Salini, Shubhas, Nature with Medicos, all of you are correct, guys. This is clear-cut case of ranula. So you know, ranula is mucus extravagation cyst in relation to which gland? Tell me, guys, it is in relation to which gland? Sublingual. So just below tongue, sublingual gland. Clear? Can you see the appearance? It is bluish, resembles frog's belly. That's why the name is ranula. And what is the treatment? We go for marsupialization. And after marsupialization, if recurrence occurs, in this case, we go for marsupialization. And even if after marsupialization there is recurrence, we go for excision. Clear? Now you tell me, what is the location of cystic hygroma? Cystic hygroma is located in the posterior triangle of neck. What is the location of branchial cyst? Along sternocleidomastoid, where? At the junction of upper 1/3 and middle 1/3 along the anterior border. So correct answer for this question is B. It is ranula. Here you can see this is the sternocleidomastoid muscle. Lower 1/3, middle 1/3, upper 1/3. What is the location? Junction of upper 1/3. It's located at junction of upper 1/3 and middle 1/3 along anterior border. So this is branchial cyst. Branchial cyst. And here, guys, you can see this is cystic hygroma. Cystic hygroma. And what is the most common site of cystic hygroma? Location, posterior triangle. It is located in posterior triangle. Clear guys? So it's posterior triangle. Okay? Very good. Now see this question, easy question. Let me see who is going to mark the correct answer for this question. Young patient comes to emergency with after high velocity road traffic accident with hypovolemic shock. Excuse me. Which of the following is best early method to control hemorrhage? Yes, best early method to control the hemorrhage. Right? Now let me tell you guys, any patient of blunt trauma who is hemodynamically unstable, yes, in all these patients we have to apply pelvic binder, and it should not be removed until pelvic fracture is excluded. Clear? So this patient is having hypovolemic shock, so obviously patient is unstable. So we have to apply pelvic binder, and if pelvic binder is not available, what we can go for? We can go for application of bed sheet around the pelvis and trochanter until pelvic fracture is ruled out. Multiple blood transfusions are given when the patients are not responding to fluid resuscitation. Immediate external fixation should not be done. Yes, because patient is unstable, first we have to stabilize. So we have to control the bleeding and we have to resuscitate the patient. Proceed for definite fixation immediately. No, patient is unstable. So we have to resuscitate and we have to apply the pelvic binder. Here application of bed sheet around the pelvis and trochanter. Clear? So correct answer is C, and majority of you are correct. Jiten, Snowcast, Harry, Varun, Roshan, Natsoben, Salini, Subhash. All of you are correct guys. So see what Bailey says related to circulation and hemorrhage. Bailey says a pelvic binder should be applied to all hemodynamically unstable patients following blunt trauma and not removed until after a pelvic fracture has been excluded. So any patient who is having hypotension in trauma, we have to treat it like hypovolemic shock, because what is the most common cause of shock here? The most common cause is blood loss. Clear guys? So we have to apply pelvic binder. Again, it's an easy question. This was asked many times in exam. I'm waiting for your reply. See the clues in this question. 28 years old patient brought to the emergency after severe road traffic accident. Attending clinician found fracture of right femur, long bone fracture. Initially he was alert, conscious, oriented with normal vitals, but after 12 hours became confused, developed breathing difficulty, skin rashes on axilla and chest. Most probable cause. Yes, Saeed Ali Abbas Rahat, Stalini Subhas, Varun, Jiten Yadav, Nat Soben. Yes, very good. Most repeated question, nature with medicos. All of you are correct guys. So whenever there is history of multiple long bone fractures, initially patient was stable, but within 24 to 48 hours what happens? Patient develops breathlessness, patient becomes confused, and especially if there is petechiae or rashes in axilla, on the chest, over retina or conjunctival fold. These are the sites suggestive of fat embolism. So what? These are the clues for fat embolism. So what are the clues? First, multiple long bone fracture, multiple long bone fracture. Second, patient is having breathlessness. Presentation should be within 24 to 48 hours. There is impaired consciousness, so patient is confused. And most important, petechiae or rashes. So there should be petechiae or rashes. And what should be the location of petechiae or rashes? Yes, axilla, chest, retina, and subconjunctival fold or conjunctival fold. Retina and conjunctival fold. Clear guys? So conjunctival fold. Clear? So if it's in axilla, chest, retina, conjunctival fold, it is suggestive of what? Fat embolism. Clear guys? Suggestive of fat embolism. Okay. Now see the next question, very easy question. Very easy question. Which of the following is not a complication of nutrition using the method depicted in the diagram? Clear? So first you can see the catheter here, the catheter is inserted into which vein? Subclavian vein. So for nutrition, subclavian vein means a central vein is used, so it's a type of TPN. What is this? Total parenteral nutrition. And guys, you know that if we are using total parenteral nutrition, aspiration is not seen. Aspiration is seen when we are using enteral nutrition. So you go for nasogastric tube insertion and give feeding by Ryle's tube, or you perform gastrostomy, you give the feeding. So the food will be collected into stomach, and when there is gastric distension, then only there is aspiration. So important point, aspiration, it's a complication of enteral nutrition. Complication of enteral nutrition. It's not a complication of TPN. Refeeding syndrome. What happens in refeeding syndrome? Patient is suffering from chronic malnutrition and you started rapid or excessive feeding. So because you started excessive feeding, what will happen? There is change of substrate from fat to carbohydrate. Whenever there is change of substrate from fat to carbohydrate, it leads to increased insulin release. So whenever there is increased insulin release, because of this what will happen? There will be uptake of electrolytes within the cells. Which electrolytes? Phosphate, magnesium, calcium, potassium. So if there will be uptake of these electrolytes in the cells, what will happen? Hypophosphatemia, hypomagnesemia, hypocalcemia, hypokalemia. So this is refeeding syndrome. Another question, what is the most common complication of central venous catheterization? When we insert central venous catheter, what is the most common complication? And the most common complication is catheter related sepsis. Most dangerous complication when you are going to perform central venous catheterization, especially in which vein? Subclavian vein. There is injury to apex of lung. So what happens? Pneumothorax. This is most dangerous complication. So pneumothorax, this is most dangerous complication. And in patient of TPN, there is deficiency of micronutrients. Because of nutritional deficiency, there can be osteomalacia. So refeeding syndrome, pneumothorax, osteomalacia can be seen. Aspiration is not a complication. Now guys, this is again a repeat question, but only language is different. Tell me, what is the correct answer for this question? I'm waiting for your reply. Tell me. Guys, I'm waiting for your reply. Snowcast, very good. Kush Avasthi, very good Kush. Jiten Yadav, very good. Okay, now see the question guys. After delivering a baby boy, 25 years old mother developed acute postpartum hemorrhage, hypovolemic shock. Massive blood transfusion was done. All of the following are major complications of massive blood transfusion except. So what happens? Whenever you give too much of blood, massive blood transfusion is done, what happens? The blood is stored at low temperature. So because of that, patient can develop hypothermia. Second, chelating agents are used. So that's why it chelates with calcium. So what happens? Patient develop hypocalcemia. Both hypokalemia as well as hyperkalemia are seen, depending upon the age of RBC. Both hypokalemia and hyperkalemia can be seen. Hypomagnesemia is also seen, but this is not the major complication. So hypocalcemia is seen, hypokalemia is seen, hypothermia, hypomagnesemia is not a major complication. So correct answer for this question is D. Now see what's written in Bailey related to complications from massive transfusion. So there is coagulopathy, there is hypocalcemia. Why coagulopathy? Because shorter survival of platelets, hyperkalemia, hypokalemia, and since it is stored at low temperature, hypothermia. Another problem, the patients who are receiving repeated transfusions over long period of time, and you know which patients, the patients who are suffering from thalassemia. In such patients, there is iron overload. Another question which is asked, each transfused unit of RBC contains how much milligram of elemental iron? So 250 milligram of elemental iron. Clear guys? These are important points which are asked in exam. Now very easy question. Hormone replacement therapy leads to, tell me what is the correct answer. Waiting for your reply. It is asked in gynae also, it is asked in pharma also, surgery also. Snowcast, Salini, Shubhas, tell me, I am waiting for your reply. Jiten, very good Kush, very good. Yes, let me discuss. Hormone replacement therapy, you know, it's a risk factor for breast cancer, so increases the risk of breast cancer. Clear guys? It increases the risk of endometrial cancer. So breast cancer, endometrial cancer. Okay. The patients who are having post-menopausal osteoporosis, in those patients you give hormone replacement therapy. So obviously it causes improvement in osteoporosis, means it decreases the risk of vertebral fracture. Decreases the risk of vertebral fracture. And very important point, that it is going to decrease the risk of colon cancer. It decreases the risk of colon cancer. Clear guys? So see the options. Decreases the risk of breast cancer? No, it increases the risk. Decrease the risk of endometrial cancer? No, increases the risk. It's incorrect. Increased risk of vertebral fracture? No, it decreases the risk. There is decreased risk of colon cancer. So this is correct. Option number D. Now tell me what is the correct answer here. Very easy question. Tell me guys. Salini, Snowcast, Jiten, Kush Avasthi, tell me what is the correct answer for this question. Easy question guys. Identify the given image of surgical instrument. So you can see how much is the degree, angle between shaft and blade. Yes, the terminal part of blade, yes, it is having what kind of angle? 90 degree. So this is right angle forceps. This is right angle forceps, also known as mixture artery forceps. Mixture, another name is Lahey's forceps. So mixture artery forceps or Lahey's forceps. Clear? This is right angle. So since it is right angle forceps, what is the use? You can catch a bleeder in depth. Second, if you want to pass a ligature around a vessel, around the pedicle, you use this instrument. Another important use, whenever we are performing open cholecystectomy, we are passing the ligature around cystic artery or cystic duct. We use this instrument. Clear? So this is the use of mixture forceps. Clear? How Rampley's, Cocker's and Babcock's forceps look like? Have a look. You can see this one first. Yes. So here you can see this instrument is having oval tip. There is long blade, serrations at the inner aspect of blade, and there is fenestration. There is long shaft also. So this is used for cleaning. Whenever we are starting the surgery, we have to clean and drape the patient. So we used to clean the patient, we are going to hold the swab. So that's why it's known as Rampley's sponge holding forceps. Second, if a patient is having abscess cavity, you can swab that abscess cavity. Third, if you are performing open cholecystectomy, in open cholecystectomy we are going to hold the fundus during dissection. So these are the uses of Rampley's sponge holding forceps. What's the name? This is Rampley's sponge holder or sponge holding forceps. Okay guys, now you can see the second instrument. In this second instrument, you can see at the tip of blade there is a tooth, you can see here tooth, and there is a groove. So tooth and groove with interlocking mechanism. It means whatever the structure it is going to catch, that bleeder will not slip. So this instrument is having transverse serrations in the blade also. This is Cocker's hemostatic forceps. What are the uses? Whenever we perform appendectomy, it is used to crush the base. In tough tissues, especially palms and soles, we are going to catch the bleeder. Whenever we are performing mastectomy, it is used to catch the bleeder. So if you are performing mastectomy, it is used to catch the bleeder. So what's the name of this instrument? The instrument is Cocker's hemostatic forceps. This is known as Cocker's hemostatic forceps. Okay guys, clear? Now you can see what is the name of this instrument. This instrument is having curved terminal part and there is fenestration in the blade. Simultaneously you can see that there is a space between blades. So since there is space between blades like this, clear? So if there is a space between blades, it is going to accommodate the tubular structure, like it can accommodate ureter, it can accommodate fallopian tubes, yes, appendix. So this is known as Babcock's forceps. What's the name? Babcock's forceps. And you know, this Babcock's forceps, it's non-traumatic. And if this instrument is non-traumatic, it is used to hold the cut edges of bladder and bowel. So this is Babcock's forceps, and here you can see the angle in the blade, especially at the tip and with the rest of the blade, is 90 degree. So this is right angle forceps. This is right angle forceps. And we discussed what's the name. The names are mixture artery forceps and Lahey's forceps. So these are mixture artery forceps and Lahey's forceps. Clear? So these are the instruments. So guys, these were the questions of surgery which were asked in INI-CET. I hope you did well in the exam, and best of luck for the results. The crowd is really highly interactive. So good luck guys. Good luck for your results.